Welcome to the Jared Powell Podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do we have with us today? Because I think we have someone special, a guest host.
We have a guest host who was requested this episode, Matt Schuster, who's a geriatrician and palliative care doc. He's in Boston. He's a medical director of Hebrew Senior Life Outpatient Clinic at Newbridge. And also, I was in the HVMA primary care program. That's what it was called at the Brigham way back in the day. And Matt was one of the preceptors of a good friend of mine and classmate, Don Sherling. And Matt brought today's topic to us. Matt, welcome to the Jerry Powell Podcast.
Thank you. I'm thrilled to be here.
We also have Parag Goyal, who is a cardiologist and associate professor of medicine at Cornell. He's the director of the program for care and study of the aging heart and director of the heart failure with preserved ejection fraction program. Parag, welcome to the Jerry Powell Podcast.
Here. Thank you.
And I know Parag from the Beeson meetings where we sing campfire songs at night. It's a lot of fun. And Nicole Superville is a cardiologist and assistant professor at Wake Forest and associate director of heart failure for the Atrium Health Southern Region. Nicole, welcome to the Jerry Powell Podcast.
Glad to be here.
So we got a lot to cover. We're going to be talking about heart failure in older adults and specifically guidelines or goals when we're thinking about heart failure. But before we go into that topic, Matt, I think you have a song request.
I do, and the song is entitled Medication. Pretty obvious reason to pick that.
What was the reason to pick that? Or will we find it in the lyrics?
Well, actually, we will find the lyrics. The band is called The Collection. It's actually a song that the lead singer of that group wrote about depression. But if you look closely in the lyrics, there's a lot of references to things that have to deal with heart failure and the effects of treatments for heart failure, orthostasis, falls, dyspnea. So pay attention to the lyrics.
Oh, yeah, Alex, give us a little snippet.
Here's a little snippet, and for those watching on YouTube, you're going to see me with the guitar playing this. For those of you who are listening audio only, Matt sent me the GarageBand version with like 4 different backing tracks. It's awesome. So I'll be singing along to that.
Feeding the beast, person. Matthew, feeding the beast.
All right, here's a little bit. I was scared of what it meant if I needed medicine, just to feel like me again and keep my demons in every now and then. 'Cause I remember when I thrived. Now I'm just trying to survive. It's like I tripped and took a dive into another life that doesn't feel like mine. But now I'm tired of sitting, aimless and drifting, trying to turn off the lights. I'm only taking my clothes off, far from the windows, keeping away from your side. So now I'm dropping the weight of the earth, just long enough to give me a rebirth. 'Cause I deserve to be well. Yeah, I deserve to be well.
I think I see it, Matthew.
Wow.
I get the lyrics, yeah?
Right. Yeah, that was actually very fitting in terms of just how patients may feel. I feel like I should steal this and put this as an overhead for a heart failure clinic.
You could just play it in the background.
Yeah.
Okay, Matt, I'm going to start off with you. What motivated you to suggest this podcast?
Well, I actually have been teaching, doing sessions about polypharmacy for many years. And in fact, as Alex mentioned in the intro, probably more than 20 years ago, Muriel Gillick asked me to help out with the geriatric modules at the Brigham Women's Hospital primary care medicine sort of sessions. And I know one of the topics I did was polypharmacy then. And Alex, you may have actually been in one of those.
Probably was, yeah.
And so it's been something I've thought about for a long time in practice. And in recent years, the pace of new drug discovery and release by the FDA, it seems to have quickened. A lot of great drugs, a few drugs we scratch our heads about. But in the last couple of years, I have a practice at Newbridge that is really old. The average age is 87. Mm-hmm. And so there's lots of folks who have heart failure, and the big majority actually have heart failure with preserved ejection fractions. And I'm starting to see that phrase when they come out of the hospital more and more often, guideline-directed medical therapy, and what that means, which is often adding 2, 3, even 4 more medications on individuals who may be on 5, 8, 10 more. So it's been that conflict between here's a guideline, here's some evidence, which I must say as a generalist, it's hard to sort through the evidence. And how do I reconcile that with what I know are some of the dangers of polypharmacy?
Yeah.
But that's why I picked this topic.
And Nicole, as a specialist, does that kind of ring true to you? Is this tension in a way?
Yeah, it definitely does. In terms of that struggle, in terms of here, you're right. You have the guidelines, you have X amount of medications to choose from. And do I apply just a, one size fits all approach in terms of, just checking off those boxes? Or do I make it a little bit more tailored in terms of my approach when I see a patient? I would say it's particularly more difficult too, because with patients with heart failure, preserved ejection fraction, a lot of times they have multiple comorbidities. And so they're already on a lot of different medications. And then, you're trying to really be selective. I personally, at least that's my approach, sometimes in terms of, what do I add on here? Where would I get the most bang for the buck? Can I really add on 3 or 4 more medications in that particular setting? And I would imagine too, that's probably a struggle for other cardiologists as well.
Yeah. So all these issues, it's very interesting because this discussion sort of mirrors why I do what I do from a career standpoint. So in training as a cardiology fellow and then as a heart failure fellow, I got very interested in this very specific subtype of heart failure with preserved ejection fraction. And to your point, Nicole, these patients are older. They've got a bunch of medical conditions. The idea of polypharmacy or a high medication burden is nearly universal. So as I was training and learning traditional cardiovascular stuff, I was kind of like, seems like polypharmacy and multimorbidity, and I should probably learn more about this. Yeah. Incorporate it into how I actually think about patients and older adults. And it links back to learning a little bit about frailty and cognitive impairment, but polypharmacy was a big one. And for the past several years, I study polypharmacy because of these issues that we're actually describing. So really important topic, and I'm excited for these next 40 minutes or so to talk this through in greater detail.
Well, can I ask a stupid question? Because heart failure is one of those things, like in med school, I think we only got taught about heart failure with reduced ejection fraction. We didn't even call it back then. We just called it heart failure. And the number of meds for that has significantly increased. So that there's this question that we will get to. And then there's this other thing of heart failure with preserved ejection fraction,
which I think we used to call diastolic dysfunction, right? When we were in training, but now has a new name, heart failure with preserved ejection fraction.
And that's not what the kids are calling it, Alex, either. Is it HFpEF?
That's right. HFpEF.
HFrEF versus HFpEF.
Yes.
What is
HFpEF?
Do we have 30 minutes just to talk about that?
Evolution there. There's been a lot of evolution, I would say, in the term or the entity, I would say HFpEF. You're right. Years ago, it was felt to be mostly just related to diastolic dysfunction. But I think the thought has really evolved far past that to where, there's a lot of ongoing research, and it seems more to be not just a cardiocentric entity, but I would say more of a systemic disease, probably. The evidence suggests more so of aging. And there's a lot of different components in terms of just an inflammatory component, things that we see in the skeletal muscle, changes in that regard. And a lot, of course, that suggests that there are different phenotypes of HFpEF. So there's still a lot, I think, that needs to be explored, and we're trying to learn more. Hence what makes it particularly challenging, I think, in terms of trying to figure out, try to get to a one size kind of fit all approach.
And it feels like, for HFrEF, reduced ejection fraction, I get it's a disease of older adults, like when you look at it, but HFpEF seems like a lot of older adults have it. It is fairly common. Does that sound right, Parag?
Yeah. So as the population ages, I think this is one of the main reasons why we've seen a much higher prevalence of HFpEF. Mm-hmm. Part of it is also, I think, the field is recognizing that there's this subtype of heart failure. I'll share what often happens when patients come to see us. They see doctors for years. They're short of breath. They have fatigue. They have swelling of the legs, edema. They have all these classic symptoms of heart failure. They get an echocardiogram, which is the right thing to do. Yeah. And the echocardiogram shows a preserved ejection fraction, because this is a heart failure syndrome with a preserved ejection fraction, which is easily measured on the echo. And so people see that, they see it's preserved, and often patients are told, there's no cardiovascular problem. You don't have heart failure. You're older, or maybe it's from another chronic condition, and so unfortunately, I think for a while, this condition for many people isn't diagnosed until you end up seeing a cardiologist or a heart failure doctor who's really honed in on this to say, actually, this is a heart failure syndrome. So yeah, it's great that we're all recognizing this condition much more frequently, because again, it does disproportionately affect older adults. And I think one key part is educating the field, not just my fellow cardiologists, but also primary care doctors, geriatricians, that there's this heart failure syndrome that is kind of sneaky and is kind of difficult to diagnose.
Any pearls on the diagnosis of HFpEF? Should I even be using that term HFpEF, or should I not follow what the kids are doing?
No, HFpEF is cool and it's fine.
I use it to tell the residents that I'm still in the game.
Yeah.
I would say that in primary care, I think we see this so much now in older adults, because there are so many older adults, that we've sort of gotten used to the idea that our questions really are for what's the most effective treatment. We use those BNPs, brain natriuretic peptide tests. Those get probably overused in following patients. And we see them very elevated in these folks with normal ejection fractions, and they have edema. So I think there's recognition, but the confusion I believe is coming from some great therapies that are on board, but the data seems to be really more effective for the reduced ejection fraction population, not the folks that we are seeing more and more.
Hey, before we jump to treatment, one more question. Is it your impression that HFpEF is underdiagnosed in older adults?
Yes.
Overdiagnosed in older adults, or about right?
So I think I would say underdiagnosed. And I was going to answer Eric's question about the pearl.
Thank you. I thought Alex was trying to bypass my pearl question.
For me, I think the biggest pearl is if you've got an older adult who is reporting to you progressive shortness of breath, don't blame it necessarily on age or deconditioning. Mm-hmm. That's the classic misclassification that I end up seeing. If it's continuing and it's getting worse, and maybe they have some swelling in the legs, there are some subtle findings on the echo, but really, think for a second, could this be this really common cardiovascular condition? Echocardiogram, maybe even a referral to a cardiologist, if you have access to that, I think is the way to go.
Yeah.
And I would say one thing, because I think Matt mentioned about the BNP levels. I think that's another pearl I would probably say to keep in mind, because some of these patients don't always have elevated BNP levels. Of course, it's a clinical picture that you're trying to put together. But when you think about, the subtype of people with obesity and HFpEF, sometimes their BNP levels could be just fine. Yeah. So I would agree, just in terms of not trying to dismiss a lot of these patients in terms of deconditioning, and really trying to sometimes hone in on the diagnosis, despite a BNP level that is not necessarily very high.
Okay, I got another question. GDMT was mentioned a couple times. What is GDMT? Sounds like a new age band.
Guideline directed medical therapy.
Is that just pharmacological guideline, or does that include all guidelines, non-pharm, exercise, things like that?
So technically, it's the pharmacologic therapies, and that term, GDMT, is just a term coined in the heart failure world, which there were lots of medicines for reduced EF, HFrEF, and only recently has there been now therapies that we call GDMT for heart failure with preserved ejection fraction.
Okay. And I promise I'm going to turn it over to Matthew, ask about the GDMT, but given that it doesn't include non-pharmacological therapies, I got a question about one of those therapies that we always ask, like low salt diet. This was actually just brought up to me by a med student the other day. He was describing his like 87-year-old grandma who was placed on a low salt diabetic diet. And like he has to convince her every day to take this, and she would rather die than continue to this diet. And he feels like he has to force her to take it. Where are we with low salt diet? Because I also feel like we target people's low sodium diets in the hospital. We target their diuretics to this, and then they just go home and they eat something completely different. So we're not targeting our intervention to what their life actually looks like.
So I have lots of strong opinions on this, but Nicole, you can go first, and then I'll go.
I too, but I'll let you go first.
So
hit me.
So excessive sodium can lead to fluid retention. And I'm not saying, I'm saying excessive sodium. So what I usually counsel on is to avoid very high amounts of salt. So what are the high amounts of salt? Pickles, olives, processed meats, eating out. I think those are the big ones. So I usually recommend avoiding those. But I don't go personally as far to say low salt diet, because the concern, and there's some studies supporting this, is that when you suggest low salt diet, caloric intake drops.
Yeah.
And when we're talking about older adults with chronic medical conditions, if you drop that caloric intake and they start losing weight because they're not eating enough, okay, great, they're not eating salt, but they're also harming themselves in other ways. So I actually explicitly will share this with patients to make sure that they appreciate that balance. I don't want you to eat too much salt, but I need you to eat enough food to live life. Nicole, I don't know what you think.
No, I try to strike that balance as well, in terms of like the salt thing. And I will share something just personal. So I have a 2.5-year-old, and during my last pregnancy, I had gestational diabetes, and boy, was it hard to count those carbs. Yeah. So I think that gave me a different perspective in terms of when I counsel my patients. I'm probably similar to you. I always tell them, no one's perfect. You're going to go out, you're going to probably join friends at a restaurant. I don't know what you all ate when you went to the Beeson Club, was it? The Beacon Club?
Beeson Conference.
Yes, the Beacon Conference. But we're not perfect individuals. So right. I tried to tell them, hey, there were days when I just wanted a cheat day and I was going to have my burger and fries, no matter what that sugar was going to be. Mm-hmm. And so I tried to practice with them more mindfulness in terms of, hey, apart from just thinking about the sodium, I want you to get in the habit of getting other clues too, particularly the weight. I've found very useful. In the mornings, you try to weigh yourself in whatever manner you choose to, and then really think about your target dry weight. So you go out, you probably have your steak. If you see tomorrow that weight jumps up by like 3 pounds, hey, that ain't muscle mass. That is probably your body holding on to some fluid. So, get in the habit of like, hey, maybe adjusting your diuretic, and they can call the office and we kind of work through it together if things aren't turning around. But I'm probably right there with you as well, that, we don't want to be too stringent. There are studies to support that. But again, mindfulness, I think, is a big issue. And that's how I counsel.
And I love this. This is like what Matt brought up, is this guidelines versus goals. People's goals are often much more than, perfect management of heart failure, or even living as long as possible. The quality of life matters more. And correct me if I'm wrong, we actually have one study, was it sodium HF, that maybe suggested low sodium diet doesn't really add much.
I believe it was that one, right,
Yeah.
Brad?
And it's actually, I got to look back. I think it's, I'm not even sure it's explicitly in the guidelines anymore in terms of low,
Oh yeah.
excessively low.
Yeah, I
I'll have to
think
double check that.
Even the AHA, I think, because I remember, when we were training, they would always say like limited to like 2 grams a day. And even the AHA was a little bit more liberal than us physicians, counseling sometimes to that 2 grams or like 1.5.
Yeah.
They at some point was doing like 3 grams or something. But certainly, I think, again, it's a practice, I think, of mindfulness and giving patients other tools as well in terms of trying to keep their fluid status in a great place.
All right, Matt, I'm going to let you ask the next question and maybe we can get into GDMT.
Well, you know what I'd like to do is just give you a snippet from a case that I've used in talking about this, and it's one of my old patients. He's 91, lives in assisted living, has been diagnosed with HFpEF, preserved ejection EF of 55%, has the usual collection of chronic diseases, paroxysmal AFib, hypertension, chronic kidney disease, adult diabetes, a little anemia, a little edema, a little mild cognitive impairment, uses a walker, puts some stockings on with an aid in the morning. And he's on, and I saw him back after he'd seen the cardiologist, on torsemide, metoprolol, rivaroxaban, metformin, spironolactone, aspirin, omeprazole, atorvastatin, Aricept, and a bunch of vitamins. And was doing okay. His weight was up a few pounds from the year before, but he wasn't short of breath. He's pretty sedentary. He had 1+ edema. So kind of from a primary care point of view, the guy's doing okay in assisted living. The quote from the cardiologist, and again, I get varied perspectives from different cardiologists. None of us are the same on this, of course. Mr. X appears adequately compensated, although weight and edema slightly increased. Recommend adding SGLT2 inhibitor and consider neprilysin inhibitor /ARB if blood pressure tolerates to meet GDMT. And I think that phrase and seeing that kind of said to me, well, this is something worth exploring.
So there's a lot of medicines I would actually change.
I was about to say there's a lot to unpack there.
And it was the idea that, well, after eliciting that long list, it almost reads as if the goal is now to add 2 more medicines, yet there's so much multimorbidity going on. And how do you know you're doing more benefit than harm? Orthostasis, electrolyte, all the things that can go wrong. And I think as a primary care doctor, I want to know the number needed to treat as far as a benefit for a patient like this versus the number needed to harm. And it's hard to get that data.
Yeah. How much is it going to help? And importantly, too, when we think about prognosis, when is it going to help?
What's the lag time to benefit?
So I'm going to add another piece to this that I think about practically when taking care of patients. Some of it is certainly the GDMT itself, the actual heart failure medicines that we as a field are often promoting because of substantial benefits. More substantial, you could argue, in reduced EF, but I do think also meaningful in HFpEF. But the other angle I want to add here, I'm a heart failure cardiologist who researches deprescribing. And so my colleagues when I would go to conferences.
That's an oxymoron. They're all there.
Would be like
contradiction, paradox.
Hey, I like you and I respect you, but I don't understand. What do you mean deprescribing? We've spent the last 20 years trying to get everyone to take more meds, not necessarily less. And my view, which is actually consistent with our field, is not that I necessarily want to deprescribe heart failure medicines or cardiovascular medicines, but I want to prescribe the right meds for the right patient at the right time. And I want to get rid of the stuff that doesn't make any sense. Why do I bring this up? The few things that you outlined, the vitamins, I don't know. I still haven't seen any data that supports a bunch of vitamins that people take. Aspirin. Why is the person on aspirin? Do they have coronary artery disease? Or is this for primary prevention, which has also fallen out of favor? He's on metformin. You might argue that you could replace the metformin with an SGLT2 inhibitor. So now We're not adding a medicine, we're actually substituting or replacing. So I just wanted to add that layer of how I think about these things, because I agree. I don't know if we want to keep add-on therapy. If we can be a little bit more holistic and think through what are the medicines that are going to provide the greatest bang for your buck, and get rid of the stuff that probably isn't going to do anything. To me, that's the first step in conjunction with understanding the patient's priorities.
I would agree with that. I feel like, especially in that age group, I do think more so sometimes of making substitutions rather than add-on. And let me even say, most times to me, I think of them as well as suggestions. I actually reach out sometimes to the primary care physician to say like, hey, let's talk about this, because sometimes they have much more long-standing relationships with these patients than me meeting them for a slice in time and trying to shuffle the deck, so to speak. But another layer I would add to it is also maybe more patient-centric. I don't know. I think at the age of 91, a patient should have a say, really, in terms of, hey, I can present you with some of the reasons I think we should make a switch. But what do you think? Do you think you want to go down that path of changing your medications? It sounds like to me that patient felt like, hey, maybe he was doing okay. His quality of life was fine. It even seemed like, they were suggesting that, hey, the physician themselves was suggesting that, hey, he's doing okay, but I may propose this to you in terms of adding on these two medications. So I think I make the patient at this point weigh in as well. I think that's another layer. And then look for areas of substitution as opposed to adding on.
Okay, I'm going to interject here. One of our first podcasts, over 300 podcasts ago, was with Nate Goldstein, who studies heart failure management in older adults, and particularly older adults nearing the end of life. And he said the best palliative treatment for heart failure is treatment for heart failure, which to me seems like it would push you to really consider these meds. And that would pair that with, I was doing some preparatory reading for this, and there was a great article in Annals of Internal Medicine that Matt sent to us that we can share in the show notes associated with the podcast. And he pointed out that actually treatment in the most frail patients had great benefit, which kind of flies in the face of well, the sicker you are, maybe the less you should consider it. Maybe it's the sicker you are, more you should consider it. So I just have these these thoughts echoing around in my head as we're talking about deprescribing, which of course I've drunk that Kool-Aid, but they're kind of in tension and contrast.
That's certainly one way to think about it. I think personally, the challenge with HFpEF, as I was saying, is I think there are a lot of different phenotypes, and a lot of times these patients have a lot of comorbidities. So I think the approach in which, the approach people might take to it, I think is different. For example, you might see some of these algorithms that tell you, hey, address the blood pressure first, prioritize the SGLT2 inhibitor, prioritize the MRA. What if somebody has atrial fibrillation? If it's somebody who has coronary artery disease, then you prioritize different, things. So I think, especially when you're dealing with the geriatric population in particular, I think it's okay to be a little bit more methodical. And again, probably trying to, at least from Parag's perspective, I wouldn't say it's necessarily deprescribing, but I think thinking about ways to substitute. But I'll open it up to you, Parag.
No, I agree everything you outlined. I wanted to address Alex's point. I have a comment for both. So the first is there's actually an AHA scientific statement on palliative pharmacotherapy that just came out in the last few months that I had the privilege of participating in. One of the points in there was exactly what you're describing, which is, well, if you manage the symptoms with heart failure therapy, some of which is GDMT, then you actually might help them feel better. And that's actually a very patient-centric, symptom-based approach that you want to use at end of life. Naturally, you want to balance that with treatment burden and pill burden, but often I do continue some of those therapies at end of life. Yeah. The second point is you made a comment about frailty. what's interesting as someone who thinks not just about polypharmacy, but all multiple geriatric condition in the setting of heart failure, which, by the way, really common, cognitive impairment, really common, frailty, really common, is that there's probably a bidirectional arrow between heart failure and these geriatric conditions. So on the one hand, you want to, from my standpoint, you want to think practically, okay, if they're frail, if they're falling, if they have cognitive impairment, they're at higher risk of adverse drug events. We've got to think through how to accommodate some of these limitations, a pill organizer, having family. But at the same time, if we can actually initiate these therapies and treat heart failure itself, you might be treating and eliminating or mitigating the contribution from heart failure itself.
Yeah, in the hospice unit that I work in, what we see sometimes is, people are on like 20 different medicines. We come in, we pretty much stop a lot of them or most of them, but maybe give them a little bit of afterload reduction and continue the diuretics, which they often were forgetting. And then they look great. And they're all, and this idea of like prioritizing the ones that are going to be most important.
Yeah.
And for me, that makes it's a little bit easier in my head to think about that with reduced ejection fraction for heart failure. HFpEF makes it a little bit more challenging for me. And I think, Nicole, you said that I should think about it more as a systemic disease. Like all of these things in your body that are leading towards, so it could be obesity, metabolic syndrome, all of these things, and aging, which I would imagine makes it very hard to answer the question that Matt brought up is like, what's the number to treat? Like, what's the right thing for this patient? Because there could be a lot of things that are causing. Is that part of the problem with HFpEF?
I think that's one of the challenges. I mean, we are part of a huge initiative called HeartShare, for example, where the NIH is investing almost $50 million over the next few years, really trying to get down to that very question. In terms of just the different phenotypes, we're trying to build a huge repository, both a registry as well as a deep phenotyping cohort, trying to just figure out the different phenotypes and maybe more targetable interventions for HFpEF. Certainly, there's been a lot of progress, I would say, over the years. But I still feel like, again, just with the work that Sanjeev Shah and others have done, it really speaks to this is not just a cardiocentric, entity. It is a disease of aging, and maybe there are multi-organs involved in terms of, us learning more and trying to approach patients a little differently.
Which, by the way, the multi-organ, multi-morbidity, even polypharmacy aspect, sodium glucose transport inhibitors, which we've talked about, SGLT2 inhibitors, are a really nice medicine for them. Why? Because you're treating multi-morbidity.
So I guess my question is, all of this talk about individualizing care for people with HFpEF, can I just click the easy button and just start them on an SGLT2?
I kind of do. I put almost everyone SGLT2. It's very well tolerated.
Yeah.
And what do I describe to them? Well, it treats heart failure. It improves metabolic health. Metabolic health probably plays a role in the pathophysiology of HFpEF. It treats diabetes. It prevents progression of chronic kidney disease. I mean, that's a huge part, just a proportion of my patients from a health profile standpoint.
I would have to say the SGLT2 inhibitors, I feel like they're one of the most forgiving classes of medications. I think they're well tolerated. So that one, I think, is, it is the easy button that we push in terms of adding those on. And then, you get a little bit more details with the nuances of other things based on the kidney function when you're thinking about your aldactone or, your ARNIs and that sort of thing in terms of blood pressure and so forth. So I think the SGLT2s for sure, I feel like that's a very forgiving class.
But I think that's one of the frustrations is that I'm obviously not an expert in the trials, but from my understanding, there haven't been regimen versus regimen sorts of trials done in this field. And I want to ask both of you, as a primary care doctor, what's most dramatic to me is when I see the harms from too much medication.
Right.
The orthostasis, the fall, the hip fracture. That's much easier to see than the 8% improvement in hospitalization and morbidity by adding drug X.
Yeah.
should I feel confident that the studies that have shown these benefits actually were adequately including folks in the old group, 80, 85 and above? Of course, to lump everyone from 65 on as the same group of patients is, it's the same as lumping, 10-year-olds with 25-year-olds to me.
So this is a great topic and a great question, and something I struggle with a lot and think about a lot. So the reality is, over the last 20 years, real world older adults have just been excluded from clinical trials. I think it's been better for HFpEF. Part of it is the average age is older, and part of it is, I think, as a field, not just in cardiology, but broadly across the country, we recognize we've got to include older adults. We have to stop systematically actually excluding these patients.
Right.
In the past, there were age cutoffs where patients of beyond a certain age weren't incorporated. So we're doing a better job.
Explode.
And dementia cutoffs, right?
So we're doing a better job, but I do still think those who are more frail, have more cognitive impairment, have more advanced kidney disease, sort of a little bit sicker older adults are not really in these studies. And so I think the question for me is not necessarily oldest old, but the more sort of physiologic or biologically aged. How do you manage medicine in those people? And my approach has been understanding what their goals are, understanding what their staging of the disease is. If they've got 6-month life expectancy, I'm going to think about things a little bit differently.
How so?
Well, I don't know if at 6 months I'm going to be as aggressive with blood pressure control, for example.
Yeah.
I think that's probably the most obvious. Some of these medications you don't get benefit within the first few weeks. It might take 6 months, it might take a year, it might take a couple of years. And so I think about that aspect. So I think going slowly and being thoughtful and trying a medicine and seeing again or communicating with them. I mean, this is the nuance in medicine that we all need. The challenge is it's easy to say, oh yeah, talk to them in a few days, talk to them in a week, have them come back every other week, because the time constraints and the way our healthcare system is built, the people at the greatest risk are these more vulnerable people. And so what happens is people just say, well, they're older, they're more vulnerable, I can't risk it. I can't start in medicine and see them 6 months later. So it's hard, is what my summary is. It's really hard.
Yeah, and I don't think there's probably not a perfect answer, I think, to any of this. And that's why I think, to me, it's a shared decision-making sort of approach when you're dealing with, patients who are elderly. And I'm talking about, 80, 90 years old, which it seems like you're referring to, Matt. I think it's just a shared decision making, and really, as you pointed out, Parag, really centered sometimes mostly with the patients and what their goals are. So to me, that's when you're really moving away from just the guidelines to probably like a more goal-oriented sort of approach in terms of that subset of patients who are really most of the times, as you're rightly pointing out, not included in most of these sort of trials. So I think it's a more tailored approach that I take. And I think, try to prioritize with the patient what's important to them. Is it adding on these kind of free more medications to your regimen? Is that going to impact what you perceive, for example, your quality of life? Because a lot of these times, sometimes we're talking about medications that the outcomes or the benefits are not necessarily driven by mortality. Sometimes it's just driven by heart failure rehospitalizations. If you're seeing a patient who's like 80-something years old and they have not been in the hospital for years on end, are they truly getting, a huge benefit from just layering on medication after medication? So it's a complex, I think, conversation. But I think when we're moving into particular age ranges, I make it a little bit more patient focused and what their goals are and what brings them quality of life.
For shared decision making is so important, but it presumes that on the clinician end that you have the right information to share, and that's feel a lot of uncertainty. And what I'm going to be.
So, Matt, do you refer, I guess, the majority of those patients to the heart failure specialist in terms of, making those decisions?
Most of them have come to me, have already been seeing a cardiologist or come out of a hospital. If they're a patient that has been mine for a long time and has developed what I believe is heart failure, particularly with preserved ejection fraction, I will use traditional meds, symptom-based, and be thinking about adding these new drugs in a sort of one by one. And I have the luxury in my clinic to see them back every few weeks and really monitor. And
so what's the typical knee-jerk reaction for most of your patients who presumably feel like, hey, I'm limping around here doing just fine, but I saw this heart failure cardiologist and they want to add on like 3 more medications to my regimen. Like, what's their typical reaction?
It's a delicate conversation. They may have a long relationship with that cardiologist. So it requires some collaboration. And, this is even back and forth between the PCP and the cardiologist. And again, it's a luxury to have the time to do that. And
well, Matt, do you say to your patient who comes in, well, I can start you on this SGLT2 inhibitor, where in this one study, 16% had worsening heart failure or cardiovascular death. The folks who didn't get it had 19.5% chance.
Right. That is not the conversation I'm going to have. Right.
Why not? That's evidence right there. I can show the graph. Got it on my phone. Right there. Evidence-based medicine.
Yeah, that's the struggle. And if I said that, the patient would look back at me and say, aren't you the doctor? I'm paying you to tell me what to do here.
Yeah. Or that doesn't sound like a lot. Or, hey, that sounds great. Nicole, Parag, what do you think? How do you convert this into meaningful numbers versus just setting potentially false hope that this will, and this is the hard thing about medicine, right? There's very few things that have a number to treat of 1. And odds are most things have a much larger number to treat, and it's not going to help this individual patient.
This one patient, right.
The number needed to treat thing, I don't know. I might say something controversial here.
Ooh, boy, I like that.
Give it to us, Parag. We love it. We love
so I think it's helpful, right? Lower number needed to treat means that the statistical likelihood that the person in front of you may derive benefit. But there's a fundamental problem here, which is that these are all population-based studies, and the results are the average effect.
Yeah.
You have no idea what the effect will be in any single individual patient. Yeah. And a lot
in
of
either direction, helpful or hurtful.
Correct.
Yeah.
And in a lot of these studies, subgroup analyses are done and, arguments could be made that there are very specific subgroups that are actually driving the results. But those are usually determined after the fact. Yeah. And so, all of that is to say, this is kind of a mess. I don't think the answer is necessarily, hey, 3% improvement. And so that's how you're going to have to make a decision. I think we got to move somehow in the direction of either sort of precision or personalized medicine. How you operationalize that, how you manifest that, I think is to be determined. I'll throw out one strategy, which is work that we're doing, which is N of 1 trials.
Oh, great.
Which are kind of, they're trial and error. They're basically formalizing what we all do in medicine.
Give me a brief one sentence of what N of 1 trial is. Then I'm going to ask Nicole and Matt another pearl from each of you when you think about heart failure. So I am going to call this your pearl. Parag, what's this N of 1 trial?
So the idea of N of 1 trial is in a single individual, you test multiple interventions and try to determine in that single individual what is most effective. That's what we do in medicine every day, but it's very informal. We start a med, we see him 3 months later. How do you feel? I think formalizing that can help us better understand how patients are feeling with the addition of a medicine. Are they having a side effect? One possible idea for future personalized medicine. We'll see.
Great. Love it. So you start gabapentin for pain, you DC it 3 weeks later because it's not working.
Then you try Lyrica.
Oh, God. Well, courage, we won't go into gabapentin anymore. Listen to our gabapentin episode from a couple months ago. Nicole, Pearl.
So I would also say one thing that, we probably don't have time to discuss is, and I know we spent a lot of time on pharmacotherapy, But we are looking into non-pharmacological things that can be very useful in this population in terms of things like exercise training and those sort of things that may be just as beneficial from a quality of life perspective, especially even things we did not touch on apart from, exercise and pharmacologic stuff, monitoring devices that sometimes help patients stay home in terms of things like CardioMEM. So I think there's a lot going on in the heart failure space and tools that we have to use. I think we've touched the tip of the iceberg and may make things a little bit more confusing for Matt on the primary care end even.
And just to follow that up, with all Delane Kitzman's work and others in cardiac rehab, I was rather shocked to read that CMS doesn't cover cardiac rehab.
Not for patients with HFpEF. And so hence why we have Rehab HFpEF ongoing, another study looking at the benefits of physical rehabilitation in patients with HFpEF. So I think more to come.
Okay.
All right, Matt, take us home. One pearl.
My pearl is an amazing piece of in-home technology called a scale, and a rule of 2 + 2. If your weight is up more than 2 pounds, more than twice in a week or in 2 days, call us and let us know.
Yes.
Love that. Well, I want to thank all three of you. Oh, go ahead, Parag.
I approve.
Cardiologist. We have all agreed on one thing at the end of this podcast. This is lovely. Alex, do you want to take us home with a little bit more medications?
But now I'm tired of sitting, aimless and drifting, trying to turn off the lights, and only taking off my clothes, far from the windows, keeping away from your side. So now I'm dropping the weight of the earth, just long enough to give me a rebirth, 'cause I deserve to be well. Yeah, I deserve to be well. And maybe I do not have enough strength for more than a couple of steps in a day, but I deserve to be well. Yeah, I deserve to be well. I'm climbing up out of this hell.
Matt, great song selection. Parag, Nicole, thanks for joining us.
Thank you.
Thanks for having me.
And thank you all to all of our listeners for your continued support. We'd also like to say a very big thank you to the donors who've donated more than $250 in the last year to support the Jerry Powell podcast, including
Asher Edwards, Jerry Gerwitz, Victoria Brond, Meg Walhagen and William Strawbridge, Jessica McFarland, James Tulsky, Susan Nelson, Sharon Brangman, Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, and Stuart Oserman.
thank you very much.